Morning, students. I'm here to talk to you about Chapter 21, which is Complications in Postpartum. Normally, all things go well. We have a young, healthy group of patients that come to the hospital to do something very natural and normal, and that's to give birth. But on occasion, there are some complications, so we need to pay attention to those. The first slide that we're going to look at is a slide that I think it does a really nice job of outlining the risk factors and complications facing the postpartum patient. So maybe you can take a look at that at your leisure. The next slide talks a little bit about the number one issue that we're looking for in postpartum, and that's hemorrhage. There are two different types. Subinvolution, which is actually the lack of the uterus contracting back down to its normal pre-pregnancy size due to atony. Atony is, as the word says, without tone. So a couple of things um, can attribute to atony, but the second type is also a non-atony cause for hemorrhage, and we'll be talking about those a little bit later. Right now, I'd like to talk to you about atony. As I said, atony is the uterus non-contracted down so that it is soft and boggy, and that's one of the things that we find. And without that tone, without it being constricted down, those vessels where the placenta was implanted are vasodilated, and of course, then they bleed. Um, Causes of subinvolution due to atony, the most common one is a full bladder. We also see things like clots or placental fragments that are left behind. Anytime we have an overdistended uterus, we could have lack of tone. That can be due to triplets or twins, multiples, polyhydramnios, too much fluid, could be excessive use of oxytocin or magnesium. All of those things can contribute to a uterus that does not want to stay contracted down. So nursing assessment, what you're going to find primarily is a boggy or a soft uterus. It will probably be deviated to the left or the right, especially if there's a full bladder involved there, which is the most common reason. The patient is going to be saturating pads every 15 minutes or so, and you may be unable to locate that fundus. The nursing care, of course, the first thing we need to do is to massage the uterus and then empty the bladder if it's full. Again, we're always going to be assessing for clots and lochial flow. Medications that can be used, first line is oxytocin. Second one, if the oxytocin fails to contract the uterus down, the second one is called methergin. Now, methergin, we need to be cognizant of the patient's pulse and blood pressure. The last one that we use, and it's pretty much the big guns, is called hemabate. Hemabate is kind of nasty stuff, causes diarrhea, nausea, and vomiting. We try not to use that unless we absolutely have to. Excessive blood loss can also cause a longer recovery period, and also may be a precursor to postpartum infection. So now I'd like to talk a little bit about the causes of hemorrhage, which are non-atony. One of the first ones is called a laceration, and we all know um, what an episiotomy is at this point in time, but a perineal laceration can be an extension of that, or just a laceration on its own. Often caused through birth trauma of, vacuum or forceps, those types of things. We also see it in a precipitous birth, which is also a fast birth. We often see it in a first-time mom, and it can be seen with the delivery of large babies. The management on lacerations is, of course, ongoing assessment. We need to be taking a look at that perineal area, and then to reassure the patient. And of course, as a team member, if things start to worsen, then we need to get a hold of the healthcare provider, and they'll make a choice of whether to suture or not. The next one is called a hematoma, and we all know what it is. Um, it is a collection of localized blood in the subcuticular layer of or perineal tissue. In this case, it's going to be found right in and around the vaginal area or the perineum. The at-risk population for a hematoma are those that were delivered with a mechanical assist. Again, we're talking about a vacuum or some kind of metal. Nursing assessment includes a perineal assessment as always. One of the things that the patient will state, and it's kind of a hallmark when you have a patient that says, no, I got a lot of pain down there with pressure. The with pressure pretty much is a giveaway that something else is going outside of normal in terms of healing. Management, we want to focus on comfort. Usually they will absorb in a couple of days, so we're looking at ice for the first 24 hours. But again, to continue, if the edema continues to grow, and the ecchymosis does too, again, as a part of a team member, you're going to get a hold of the healthcare provider to look further into what we can do for this patient. If it is starting to heal, though, and we're just doing comfort measures, the use of a peri bottle with warm water is often very, very effective. Remember to teach the patient to pat dry instead of wiping. Next, we're going to be talking about other issues that may cause postpartum hemorrhage. We're looking at the retained placental fragments, placenta accreta. Those two are kind of common. So another cause for postpartum hemorrhage is retained placental fragments. The uterus cannot contract where a tissue fragment was or still is embedded. It is common with the delivery of a premature baby because that placenta is really not ready to disengage. Excessive bleeding is noted, and of course the uterus is boggy. The healthcare provider may attempt a manual removal of the pieces. If they are unsuccessful, the woman will be treated with what's called a D&C, which is a dilation and curettage. And that patient is taken back to the OR and given something for the pain. Remember that this is the patient that you're going to be watching for infection for later. With regard to a placenta accreta, in a rare instance, the placenta is embedded in an unusual manner in the myometrium, which is the inner lining of the uterus. There are 3 types of placental adherence complications. The one that we in practice see most frequently is called a placenta accreta, which is a slight penetration into the myometrium uterine wall, and that's another patient that has to be taken to the back, and hopefully they can manually take that out, take the placental out. Nursing assessment will reveal obvious bleeding is caused by large placental pieces that are left behind. Smaller bleeding is later. Typically after the delivery, you're going to see the doctor turn around and look at the placenta that's in the pan because they want to make sure that they got all the pieces out, all the pieces of the lobe. The next slide is kind of a pictorial of some of the things that we've talked about: lacerations and retained placenta and uterine atony, subinvolution. These are all terms that you should probably become, fairly aware with. The next slide is a picture of what we would see. Actually, the top picture is what we're looking for. That's the preferred one, a small amount. The other two amounts are quite a fair amount. Notice that the large picture on the blue pad, when you are checking for bleeding on your postpartum moms, you want to make sure that you're checking the blue pad under the patient, because often that lochia that's coming out, rather than hitting the pad, which it may, still may go down farther and get onto the blue pad. With hemorrhage, we should probably talk about hypovolemic shock. It is always an emergent situation in which the body organs are severely compromised. Vessels constrict to divert available blood to the brain and the heart. Medical treatment is aimed at restoring circulating blood volume and eliminating the cause of the hemorrhage. The patient is given volume expanders such as albumin, lactated ringers, blood components, packed red blood cells. Further treatment includes monitoring tissue perfusion and fluid restriction. Unfortunately, classic signs may not be apparent until 30 to 40% of loss has occurred. Symptoms of shock include increased weak pulse, decreased BP, increased respirations, pale, clammy skin, and increased anxiety. Okay, postpartum DIC. I'm going to assume that this is a term that you have seen in the past, but we're going to talk about it today as it refers to our postpartum patients. DIC is also known as consumption coagulopathy. It is always a secondary diagnosis. Technically, it is a pathological form of clotting that consumes large amounts of clotting factors, causing widespread bleeding. This abnormal clotting occurs in response to extreme bleeding at a site, often found with placental abruption. Extreme bleeding occurs, causing platelets and fibrin to rush to the site, leaving the general circulation depleted. I like to call it the Pearl Harbor effect. I hope maybe this helps you to remember it. I remember watching the movie Pearl Harbor, and before the Japanese invaded Hawaii, I remember the general of the Navy standing there and being told from Washington, D.C., that he needed to send all of his ships over to Europe, where we were already engaged in a lot of warfare. We had joined World War II actually in the European front first. And his thought was, you are cannibalizing my station here, sending all of my defenses over to Europe, which left him wide open to the attack from Japan. And this is basically about the same thing. There's such an issue of bleeding going on someplace else, usually at the uterus. All of the clotting factors are running there to assist, leaving the rest of the body wide open for bleeding. DIC is triggered by release of tissue thromboplastin, and it enters the maternal microcirculation through the placenta site. High-risk groups include those that are having an acute postpartum hemorrhage, folks that had an abruptio, patients diagnosed with an amniotic fluid emboli, or those patients that had a fetal demise. Diagnosis is usually done by clinical findings. What do we see? We see uncontrolled excessive bleeding. We see petechiae. We see bruising. We see hematuria. We see occult blood in the stool. Management is number one, remove the cause. Whatever's causing the bleeding, do something to treat that. Stop the blood coagulation by using heparin. Most students think, well, if you're bleeding all over, why would you use that? Heparin will stop the malformation of all the coags going to that site. You're also going to replace the blood and factors with blood packed RBCs, fresh frozen plasma, cryoprecipitate, fibrinogen, and platelets. You're going to continue to assess the clotting factors. We're looking at a PT, PTT, platelets, fibrinogen, FSP or FDP, and D-dimer. All right, let's look at phlebitis. Another complication that the postpartum woman is at risk for is DVT. We know pregnancy is a necessary hypercoagulability state, but this puts our postpartum patient at a greater risk for thrombophlebitis. It is defined as the formation of a blood clot inside a blood vessel. It's caused by a phlebitis or a partial obstruction, and it can be an extension of endometritis. Assessments includes the obvious is a unilateral edema. Usually it's the lower extremities. There is pain and tenderness. Sometimes we see a positive Homan sign. Um, that's where we dorsiflex the foot and assess for calf pain. It's often warm and tender to the touch. The high-risk populations are patients with outstanding varicosities, those that are obese, and increased maternal age. Treatment includes an assessment for the pulmonary embolism, elevating the affected leg and bed rest, never massage the area, and support hose. Medication includes antibiotics and pain medication. They'll use analgesics, nonsteroidal, or an anti-inflammatory. Application of moist heat, heparin, and blood coag studies. Preventatively, this is why we want to get our patients up and moving early. So early ambulation, avoiding tight clothes, avoiding prolonged standing and sitting, and avoiding stasis. I apologize for the car. Pulmonary embolism is a blood clot obstructing the pulmonary artery. Usually the causative agent is a dislodged DVT. Why are pregnant patients at risk for thrombophlebitis? Again, it's the hypercoagulability state with poor venous return and blood stasis. Signs and symptoms. Another hallmark sign. Sudden onset inability to breathe. Patient says she'll sit straight up and says, I can't breathe. As you can imagine, the next thing that you see is lots of apprehension. We may see cough, you may see some blood coming up, but most of all, there is pleuritic chest pain along with not being able to breathe. As you can imagine also, it is an emergent situation. The treatment is continuous IV heparin until symptoms have subsided. Risk factors include pre-pregnancy varicosities, obesity, advanced maternal age, and smokers. Another reason why not to smoke. Other risk factors include elevated fibrinogen levels, dilated lower extremity veins, long periods of inactivity, and prolonged delivery time or time in the stirrups. Let's talk a little bit about an infection. That's another postpartum problem. It's defined as any infection of the reproductive tract that occurs within 28 days of delivery. When we look at endometritis, we see the placenta attachment is especially vascular and now is an open portal, especially after delivery, for the entry of bacteria. So it is a common spot for infection. Prognosis is dependent on a couple of things. What was the mother's health going into the bacterial infection? How long was her bag of waters ruptured? Did she have any hemorrhage with vaginal exploration after the birth? Did she have pre-existing anemia? Well, did she have a history of long labor, which would have included increased vaginal exams and internal leads? And to what degree do we see uterine involvement at the time of the invasion? More vasodilation, greater invasion. Okay, I'd like to talk a little bit further about infection. We've learned that two particular markers that we've used in the past, which is temperature and WBC levels, are typically good to use with other patients to diagnose or assist in diagnosing infection. What we have learned also is in postpartum, these are not reliable in and of themselves. So these two tools really need to be used in conjunction with looking at the whole picture clinically speaking. So we know because first postpartum day, it is not atypical for a patient to have a low grade temp due to dehydration. Along day 3 or 4, the patient could be febrile with onset of breast milk. And normally after delivery, WBCs can be seen 20K to 25K, so 20,000 to 25,000. So nursing assessment for infection includes a temperature of an oral temperature of 100.4 or greater for 2 consecutive 24-hour periods. Perineal infection, we need to be looking for localized redness, foul smelling drainage, and RETA. Now RETA isn't RITA, RETA is REEDA. And what I like about this is that you can use this for any incision at all. It stands for R is for redness, E is for edema, E is for ecchymosis, D is for drainage, and A is for approximation. When we're looking at a peritonitis type of infection, normal signs of infection will be seen along with a rigid abdomen. Endometritis, we have uterine tenderness, chills, malaise, loss of appetite, tender uterus, and frequent small amounts of urination. Management, of course, hopefully early diagnosis. Nurses will be asked to obtain a culture and sensitivity, and typically we'll see an IV antibiotic started. Of course, we always teach good hygiene, wiping from back to front and washing your hands frequently. Telling the patient or teaching the patient to empty the bladder to prevent a UTI. And no bare feet. How often do we see patients that get out of the bed, they say, yep, I got to go to the bathroom before you check my fundus. They hop out of the bed, they run to the bathroom on that tile floor with bare feet. They jump back into the bed, tuck their dirty feet up under their bottom so that they're comfortable, and all of that bacteria is right there in the bed. Yuck. Observe the incision. Causes, some of the causes that can be a problem are retained placental fragments, internal monitoring during labor, and again, exploration of the uterus after delivery. The other types of infections that we see in postpartum, of course, is the UTI and polynephritis. Pardon me. UTIs can be asymptomatic, or the patient may experience burning and pain, incontinence, fever, proteinuria, hematuria, WBCs in urine. Pregnancy or pregnant patients have an increased risk due to dilation of ureters, a large volume of urine that is held, urinary stasis, and an excellent medium for growing microorganisms. Polynephritis kidney infection diagnosed by uterine culture. Classic sign is CVAT, which stands for costovertebral angle tenderness, aka flank pain. These young ladies come in and they are very sick. They have chills, horrible pain, they're throwing up, they've got fever. Um, in that particular case, we are treating symptoms and antibiotics. Okay, what else we want to talk about? Structural complications. When we look at postpartum, we're looking at uterine inversions and or a prolapse. Inversion literally is where the uterus turns inside out. Thank goodness it's rare. There are two different types. There is the complete and or partial. Um, some of the risks or reasons that we see these things is if we have a placenta that is implanted in the fundus as opposed to a right or left side or anterior or posterior, then sometimes their implantation is deeper than what it should be. So when the placenta starts to come out, it's bringing the uterus with it. Another reason that we could see an inversion is what's called a vigorous fundal massage, where the doctor's trying to massage to get that um, to get the placenta out, or excessive traction on the cord. Signs and symptoms are obviously in the complete, you can obviously see the uterus come out. In a partial, it's sometimes just felt. So when you put your hand up on the patient's up on her abdomen, you cannot feel that fundus. It's a dent, it's a depression in that area, along with severe pain and lots of bleeding. So what we have to do is take the patient to the back. The doctor manually puts the uterus back in, and we're looking at 7 to 10 days of antibiotics. Now, a prolapse is where the uterus is tilted, either coming forward or backwards, more often than not forward. And it's usually due to some kind of birth trauma, or often from a precipitous delivery. It could be from multiple births. And in that case, that is taken care of, again, manually placing it back, and then that patient is followed up in the doctor's office, and perhaps surgery later on. One I didn't put on the list here is called rupture. A uterine rupture, again, it doesn't happen that frequently, and thank goodness, because another emergent situation. Often we see a rupture on a patient that is attempting to do what's called a VBAC, which is a vaginal birth after a cesarean section. And those kind of complications usually occur along the old scar. slide is going to be talking about postpartum affective disorder. We've all heard about the postpartum blues, and of late, I think we've all heard of depression and psychosis. Postpartum blues is not normal. I'm not going to say it's normal, but it is, it's commonly seen. We have ways to identify these things. In the past, what we've seen is that we have patients that over the first couple of days after delivery, at one moment they're laughing hysterically, and the next moment they're crying, and they'll even say to you, "I don't even know why I'm crying. I'm perfectly happy. Things are wonderful." All of these brief emotional shifts are due to hormonal changes, and they come and they go and kind of expected. Um, the next thing that we see, which is a little bit more severe, is what's called a postpartum depression. Now, depression can be seen up to 20% of women. It can be characterized as overwhelmingly sad, extreme fatigue, as opposed to those that have the blues. They are unable to cry. Um, Depression patients have increased anxiety. It leads to their inability to care for themselves or their baby. We now have tools in place, and it's not at when our textbook was written, it was not established that it was mandatory to use these tools in all hospitals that had an OB department. But in my practice, and I've been in at least um, uh, 5 different hospitals, everybody is using, it's a 10 question, X the box if this applies to you, document tool that's given to the patient when they come in, and they're able to fill it out prior to their going home. The hopes is that can we catch, or can we identify folks that may be at higher risk of going home and developing postpartum depression later? Can we catch this before they are discharged so that we can follow up on them? We've all heard about people that heard voices. That's something totally different. That is depression with psychosis. Psychosis is specifically voices telling the mother to do something, like, you know, unfortunately, drive the station wagon off the edge of a cliff loaded with kids in it. So we want to try and catch those people before they go home to see if there's something that we can do for them. Last thing that we're looking at in chapter 29 is maternal death. Um, it is rare, and thank goodness for that. The sad part of it is most of the time it's unexpected and unplanned. And not that anybody could ever plan for um, a life lost, but especially a life lost at a very young age, dealing with what is typically a very joyful time, which is giving birth. So, maternal death does differ from anticipatory grief. Young patients at this point in their life may not have ever experienced this type of grief. Most families that are giving birth still have, probably pretty young parents and grandparents that are still alive. Um, Thankfully, we have hospital protocols in place that, although they may differ, are usually pretty good guidelines for how we would go about helping this family go through the stages of grief. Um, the As with most times, the team approach is the best. This is the time where you're going to pull in the obstetrician, the perinatologist, the nurse, all of those folks are going to come forward and do what they can to help the family. There, of course, is going to be a first meeting, and the whole goal there is to demonstrate empathy and compassion for the family. Um, One of the things to think about if you have a surviving infant, then it's likely that the parents or the surviving parent and the grandparents and family is going to want to see that baby. And of course, you want to encourage that. The more that they see the baby and hold the baby, the better it is for both. Um, then, of course, the process goes on to later assist with the next step. But that's all dictated by how the patient's family is moving forward. So I hope that some of this information that I've given you on maternal complications can help you, and I wish you a lot of good luck. Thanks.